All right, good afternoon, everyone. My name is Kanya. I'm a nephrologist and a postdoc fellow under Professor Arminu Bello at the UFA. I will be presenting the organization and structures for detection and monitoring of chronic kidney disease, or CKD, across the world, countries, and regions. So this study is a part of the Global Kidney Health Atlas, supported by the International Society of Nephrology, or ISN. CKD has been a major health burden globally for a while, especially when they progress to kidney failure, which require dialysis. So early detection and monitoring of CKD will in turn facilitate timely modification of risk of disease progression through proven therapeutic interventions. Although there are established guidelines and tools for CKD detection and monitoring for a period, however, the implementation in the real practice is still low and variable among multiple countries and settings. Therefore, we aim to evaluate the capacity for early CKD detection and monitoring across ISN regions and World Bank country classifications. So we conducted a multinational cross-sectional survey in 2022. We distributed an online questionnaire via the Red Cap program to participating countries through the ISN regional boards. In each participating country, we engaged at least 3 key stakeholders, including the leader from the National Nephrology Society, a policymaker, and a patient advocate. Each data will then be validated by the regional boards and cross-referenced with the published literatures and reports. We compare data among ISN regions and World Bank country classification as shown here. Of all 191 countries invited, we received responses from 167. Among this, 12% were low-income countries, half of them were middle-income countries, and 38% were high-income countries. This covered around 96% of the estimated global population. Of all the countries, only 19% had available CKD registries officially, which is the key surveillance systems for CKD monitoring. In this map, you will see that most of the countries are labeled in orange, meaning the absence of the CKD detection program implemented as part of their national policies or guidelines. Only 25% of all countries have such programs, with more common in upper middle to high income countries. Of the countries that have such program, you will see that half of them had adopted active case finding strategy in at-risk individuals, and the other half used the reactive approach, which means just screening in the routine encounters. Interestingly, we will see that even in the area with very high prevalent areas, like prevalent of CKD, like Latin America or South Asia, the rate of active case finding strategy was still rare. So this is the graph of talking about the active case finding. Routine screening in those with diabetes and hypertension which is the 2 most essential factors for CKD, were common in all levels. However, the testing among elderly and high-risk ethnic groups and those patients with family history of CKD was still only common in high-income countries. This is the measurement tools that we use in CKD detection and monitoring. We'll see that for the auxiliary tests like blood pressure, height and weight, and serum glucose, this is available and robust across all countries and all levels. Most labs were, of course, more accessible in secondary or tertiary care levels than in primary care levels. For the CKD diagnosis, the standard guidelines recommended the use of dual assessment of kidney function and albuminuria in order to diagnose this. We'll see that although serum creatinine and qualitative measurement tools for albuminuria is common across all levels, but the gold standard, which consisted of the EGFR, the estimated kidney function, and the UACR, which is the quantitative measurement of albuminuria, were there are more disparities among income levels. The radiology services, which included kidney ultrasound, were available across all levels, across all income levels. But the pathology services, there are more disparities among income levels. This could limit the diagnosis of certain causes of CKD that require kidney pathology, for example, glomerular disease. So in summary, this study represents the largest global survey on capacity of CKD detection and monitoring that engaged key stakeholders at both regional and national levels. We found gross deficiencies in the availability of surveillance systems and tools for early detection of CKD. Only 1/4 of countries had the national policies for CKD detection, and access to the gold standard testing was limited, particularly in lower income countries. You will see that in this study, the findings of us focus on the healthcare policy and CKD detection program, which we found the heterogeneity, but this is just the tip of the iceberg. There are many more factors behind this. So in order to enhance the capacity on CKD detection and monitoring, we propose that the pivotal role of the stakeholder collaboration, recognition by policymakers, resource allocation, and healthcare literacy, which means the public engagement, in addressing the CKD as a global healthcare challenge. Early CKD detection and treatments to slow CKD progression and to modify other additional risk factors will eventually improve the clinical outcomes. However, it is crucial that they receive such interventions to yield most benefits and cost effectiveness of CKD detection. In conclusion, we found the global heterogeneity in the organization and availability of structures for CKD early detection and monitoring. We need ongoing efforts for bridging such disparities, especially in underserved regions, to increase awareness and improve healthcare policy, and at the end of the day, to optimize CKD detection and reduce the growing burden of CKD in the global scale. I would like to thank the ISN and Professor Bello and Professor Opeishi and our all collaborators for their efforts in this project. Thank you.